long have been calling and campaigning for changes to that low-cost access system for some time now. Is this all you're going to do? You're not going to do a whole change to the system like they've been asking for?
Well, this is a very significant step along the way. So if you look at very low-cost access consultations, I mean, that already covers 1.4 million New Zealanders. Obviously, we looked at a range of options, but now with this, we're extending that coverage very considerably. Of course, we want to have a targeted system. These 600,000 people, by definition, that is the development of a targeted system, but we're not touching those very low-cost access practices. So the key thing is, of those 1.4 million New Zealanders already receiving heavily subsidised consultations, they are not going to lose any of that benefit.
Does this help solve some of those inequities in the system, though?
Well, it means that if you look at those very low-cost access practices, there were 600,000 people outside those practices on low incomes who were not getting low-cost consultations, and now they are. So that really does solve that inequity. Absolutely, it does.
And in terms of changing the eligibility for community services card, can you give some more details about who will be able to access them now who don't?
Yeah, so it's people on income-related rents and receiving accommodation supplement. So we had the community services card in place. It's been a long-standing device which has to some extent been underutilised. There's a long history behind it, but it gives us an immediate system we can roll out to target these subsidies where they are needed, and that's these 600,000 low-income New Zealanders. So it's a very clean and efficient way of delivering the care where it's needed in a very short time frame. This is going to be rolled out by the 1st of July next year. So
how much
it's going
is
to be
it
good
going to cost?
It's $380 million over 4 years. And so the important point about that is this increases the funding in primary care by 10%. So we're now going to be spending over $1 billion a year on primary care. So that's medical care in the community.
Will you look at further addressing the criticisms of the BLCA that it is not targeted to the right areas?
Well, this really does make considerable progress around that. So VLCA currently covers 1.4 million New Zealanders. None of those people are going to lose any of their access or benefits, and this is an add-on to that. So if you look at it comprehensively, between this and free under 13s, which costs $40 to $50 million per year, you've now got over half the New Zealand population either getting free or very cheap GP consultations. And that is going to make a significant difference in terms of literally the health of the population over the years to come. So, this is the most significant announcement in primary health care for many, many years.
Why is this policy needed now? Has it been getting more difficult for people to access primary care like GP visits?
Well, we've wanted to have a more targeted system. Some people have told us that affordability is an issue, but at the same time that's been a bit of a mixed picture. So if you look at the New Zealand Health Survey, the percentage of people talking about the cost of prescriptions as being a factor has actually dropped over time. But there are other people saying that in any given year, they've got to take into consideration the cost of going to a doctor. And for 600,000 extra people, that consideration has now dropped way, way down, because they could be spending anything from $40 to $60 for a GP consultation now. If they're not going to a subsidised practice, that now drops way down to $18, so really significant.
Because the government's also had to lift accommodation supplement payments, you've had to cut GP visit costs. So is this an admission that some basic costs have sort of got out of whack with income rising?
It goes back to what the Prime Minister said, 9 years of really prudent fiscal management, knowing how to manage the economy, and actually that was down to Bill's time as Finance Minister. We are now in the position to do many of these things which we've wanted to over a long, long period. So we've got some real options, and those dividends of growth, are going back first of all to the most needy New Zealanders in the case of health, which is 600,000 extra low-income New Zealanders getting these very cheap consultations.
So everyone who gets some kind of accommodation help from the government will qualify for this?
If you're on IRR or AS, yes.
So if the economy keeps getting better, the surpluses keep getting bigger, can you see these costs falling further? Can we see $0 GP visits?
Well, look, this is a significant announcement today. I'd just enjoy this one. Yeah.
Are there enough GPs to accommodate what is likely to be an increase in people going to doctors?
Well, look, I don't know that there'll be an increase in people going to doctors overall. We do need to get, we're training enough doctors out of medical schools. We've doubled the numbers of GP trainees. The main issue on the GP workforce is actually where they're distributed in New Zealand. So we need more GPs in our rural areas, but we've got strategies in place to address that. They're quite detailed, but basically Health Workforce New Zealand is working with the universities to get more young doctors exposed to rural medicine early on.
But 500,000 people didn't go to the doctor last year because of the cost. If you're saying that you won't see more people going, surely those are the people you want to be going to.
No, well, it's not quite that. Like, what they said was it was a factor in their decision making, and so we want to remove that worry for people. Look, if you've got an older person who's concerned about a cough, feeling unwell, you know, a lot of these patients have very complex medical conditions. You want them to feel they can go to their doctor, that they can afford it, rather than thinking, oh, wait a week or two, and then actually they end up in hospital much more unwell, and you know, obviously that has a financial cost in the system as well.
Do you have a value on what you could save by having them first at the GP?
Well, we need to do much more modelling around that over the long term, and don't forget this is a party announcement today, so should we have the privilege of being re-elected, we'll then be able to get the officials to, you know, model that sort of work. But
would it be a stretch to say that it could save lives?
Oh, it will definitely save lives, there's no question about that. It will save lives. People will be well up because they will not be taking cost into consideration to anywhere near the same extent as they would have previously. So I think you'll find 600,000 people greatly encouraged by this announcement today.
So people have been dying because they can't afford to go to the doctor?
I wouldn't say, I wouldn't stretch it that far, but what you can say is, look, it's very clearly accepted that early access to general practice services keeps people weller and stops illnesses from progressing to a more serious stage.
And are you saying that we won't need to employ more GPs because we've got enough to
Well,
cope with, you know, people having cheaper visits?
Yeah, we won't need to employ more GPs specifically for this initiative, but as the population grows, there's no question we do need more GPs. But under the term of this government, we have doubled the number of trainees funded each year in general practice from about 90 to around 190, around that.
What about people trying to physically access a GP, particularly in smaller impoverished areas?
Yep, so it's more of a problem actually in rural areas. So as I said, we're working with medical schools around what we can do around that. So they, both Auckland and Otago, are sending final year students out into rural areas to do part of their training. There's schemes around that. Also now for your registration year, your year after graduating from medical school, you can do that in the community, and there will actually be a community required component. So, you know, the strategy is really around exposing students and young doctors early on to, you know, the rural environment, because, you know, a lot of our graduates from the city have never had exposure to rural medicine. So there's a whole lot of things we've got to do. Voluntary bonding has also been really successful. You know, scores of doctors have been through that. So there's a full court press strategy on making sure we can get the doctors that we need in rural areas.
Are there any practices where it's cheaper than $18?
Well, you know, practices do have discretion, so I'm sure you'll be able to find that. But the point is, this is an $18 cap.
And you know, when you unveiled the GP for GPs for under 13s, there was sort of GP practice buy-in for that.
Absolutely.
Will this not apply? You know, if you've got a community services card, it will be $18.
Yeah. So look, that was incredibly successful. So 99% of general practices took up the free under 13s. We will be working with general practice around the subsidy rates to ensure that the take-up is at least 85% of practices, but we want to get well up beyond that.
So you do have to have their buy-in for this to happen?
Oh, look, it is going to be a generously structured subsidy, so it will be to their advantage to do this, absolutely.
What happens to those who don't?
Well, general practices in the end are private businesses, and, you know, effectively they do compete for patients. What I can tell you, you know, the existing very low cost access scheme, the complaint from GPs has been that they're not in it So, people want these subsidies, not only the patients but also the practices. But I think you're going to find that, once we've worked through all the detail and GPs see the subsidies they're getting, people will want to be in this, because this is actually what they've been asking for. And Peter Moody's primary healthcare funding report, which came out over a year ago, this was actually the solution that they were looking for, using the community services card as a proxy for low income.
Sorry, can I just get you to explain again why you don't think it'll lead to more people seeing doctors if people are saying the cost was a reason for them not going, and you say this will get rid of that barrier? It
was a factor in them considering whether they could go to a doctor overall. It's not going to grow practice populations, it's by definition will still be the same number of patients rolling up to any given practice. But what we've seen in the past, like with the 3 under 13s, there was an initial small spike, but then it evened out over time. And I'm absolutely confident general practices will be able to cope with this. The other thing is general practices have wanted this. That's all the feedback we get.
So they factored it in, they thought about it, but they still went anyway.
Sorry?
They factored it in,
it's
but
hard,
they went anyway.
It's hard to know what that meant for every single patient, obviously, because you're dealing with thousands. But feedback in the health survey was it was a consideration. So someone might say, oh, look, I haven't got enough money this week to go to the GP. I'll just see if I get worse or better, or I might wait till I receive a payment in 2 weeks' time. Whereas what we want is for these 600,000 people to say, hey, I feel like I need to see a doctor, I'm going to go today.